So hello everybody, nice to meet you. My name is Koutsenok. I'm a psychiatrist by training, and my specialty is addiction psychiatry and the treatment of patients and people with substance use disorders, with drug use disorders. For many years I've been working at the University of California, San Diego as a faculty member, and I was the director of the Center for Addiction Training and Research. And for the last 8 months I'm here in Vienna in my capacity as the Chief of Prevention, Treatment and Rehabilitation Section at the United Nations Office of Drugs and Crime in Vienna, and it's my pleasure to meet all of you and to share with you some thoughts that could be of some use to you and could be beneficial for all of us to review and think about. Over the last many years I've been traveling around the world, and as you know, the field of substance use disorders, drug and alcohol disorders, has always been filled with mythologies, misunderstandings, ideologies, political views, and all sorts of things, and it's quite understandable. Some of those misunderstandings are very consistent, and traveling around the world, working with people from different cultures and different countries, I noticed that some of these opinions, some of these points of view are very, very consistent and stable. I'm going to one place on one continent and I hear it, then I go to another place and I hear exactly the same opinion. So I decided it makes sense to make a collection of most common misunderstandings, at least in my experience, most common consistent misunderstandings about the nature of addictive disorders and the nature of treatment for addictive disorders, and to review with you some of those statements and some of those opinions, because it is likely you have already heard or you will hear the same things, the same ideas in your professional life. So the title of my presentation is Common Misunderstandings and Mythologies about Substance Use Disorders. What do we have, what do we know from science, and what do we have in real practice? As a way of getting started, I would like to define, at least to give an operational definition, what do I consider as a scientific mythology, as a myth. So myth is a belief for which we either don't have evidence it is correct, or we do have evidence it's incorrect. And the evidence comes from science. The only way to get a reliable information about anything is to study, and to study it using scientific, reliable scientific methodology. So this is where the evidence is coming from. And perhaps one of the most common, one of the most typical mythologies that is consistent around the world, and we have heard it, I've heard it many, many times, are the expectations that the whole society and very often policymakers place on us. By us, I mean people who provide treatment, prevention, treatment and rehabilitation for patients and clients with substance use disorders. Here's what the society and policymakers expect from treatment. This is a very nice, very simple, relatively logical, and a totally wrong model. And the model is that we have a drug-dependent patient coming to our offices for our services. We provide the patient with medications, treatments, services. We do all the magic that we are capable of doing. And at the end of this process, we have a non-drug dependent patient. This is a logical model, and why this model is wrong, I will talk about it a little bit later in this presentation, because it's important to review it. But prior to that, let me review some other statements or some other misunderstandings that, as I said, are very, very common around the world. This is one of them, and I'm sure you have heard it as well. The question, why should we treat these patients since it's their choice to use drugs, and now we need to treat them. They made the wrong choice, and because of this wrong choice, they have the problem. Well, let's review what do we know from science. And the science actually shows us that the process is much more complicated than people often think. Yes, there is an element of choice, particularly at the beginning of the drug use. When teenagers start experimenting with substances, there is an element of choice. The problem is that many of the teenagers, and this is the typical age when substance use starts, many of the teenagers are genetically more likely and physiologically are more vulnerable than other teenagers to develop difficulties. The truth is that most people who start using drugs do not develop dependence. Some do. And it's really important to remember that some of the teenagers, some of the young people are more likely to continue using and develop problems. It is also important to pay attention when we talk about choice and the ability to make choice, to pay attention to two very important facts. One, making a choice in general, decision making, is a social skill. Nobody is born with this skill. Teenagers usually, young people usually are not very good in making choices. Their choices are not well balanced, and sometimes the risks they're taking are not well measured, because the social skill is not well developed yet. There is another physiological, neurophysiological reason why young people, particularly teenagers, their choices sometimes are more than questionable. If you think about the way our brain develops, the human brain develops backwards. By the time the baby is born, the backside of the brain is already well developed, and this is the part of the brain with very important functions to maintain our vital functions like vision, heart rate and temperature, breathing, and many other things. So by the time the baby is born, this part of the brain is well developed. Over time, around the age 12, 13, 14, the middle part of the brain gets developed. And the middle part of the brain is the emotional brain, this is the part of the brain responsible for our ability to experience rewards, pleasure. In this part of the brain, our mood is regulated, the impulsivity, the sleep pattern, some of the appetitive behaviors, they are regulated by the middle part of the brain, and we call this part of the brain a mesolimbic brain. So this is, if you wish, an emotional brain. And around the age of 24, 25, so relatively late, the frontal part of the brain gets developed. And the frontal part of the brain is the thinking brain. This is the brain that helps us to make right judgment. This is the part of the brain that serves as a brake when the emotional brain tells us, let's do it, let's have fun, let's experience it. The frontal brain tells me, well, hold on a second, think again, because you remember what happened the last time you did it. So when we are teenagers, the middle brain, the emotional brain, is well developed around that age. But the thinking, the frontal brain is not yet. This is why when we talk about choices made by teenagers, it is really important to remember that the process of making choice, any kind of choice, is significantly much more complex, and teenagers, even purely physiologically, are not capable yet to make choices the way adults would like to see. This is the pattern our brain gets developed from the backside of the brain well developed, and around the age of 20-24, the frontal brain, the thinking brain gets developed. So this is a process that takes longer than we thought. This is why teenagers make their choices. The decision making in teenagers happens within the middle brain, the part of the brain that has a number of structures, amygdala, hippocampus, nucleus accumbens. So this is the emotional brain, while in adults, the decisions are made and the choices are made by the frontal, by the thinking brain. Another very common mythology and very common opinion is, even in practitioners, even in medically trained people, is, well, people are using drugs, why they don't just stop? If they stop using drugs, well, they will be fine. And it's their, again, it's their wish, it's their will to stop using drugs. Let's think about it. A very common opinion, many people believe that people continue using drugs either because they don't know they have a problem, so what is missing is the knowledge about the problem. Some people believe that people continue using drugs because they don't have skills to stop, so the skills are missing. There is a very common belief system, particularly in criminal justice practitioners, that people continue using drugs simply because they don't care, or a combination of these three. Either knowledge is missing, or the skills are missing, or the emotional part. They just don't care, and that's why they continue using drugs. If these explanations are correct, you don't need these presentations because the solutions are very simple. If people are lacking knowledge, let's give them knowledge and they will stop, right? If people are lacking skills, we can give them skills and then everybody will stop using drugs, right? Or if people continue using because they don't care, well, let's make them feel uncomfortable enough, put them in prisons and they will stop. Well, we all know how ineffective these strategies are. The process is much more complex. And in fact, in clients, in our patients, because of the dysfunction, because of the pathophysiology, particularly within the mesolimbic brain as a result of chronic drug exposure, their continuation of drug use is actually outside their voluntary control. It's much more difficult than just say, no, I will stop. Some people can do it. Most people with developed drug dependence cannot. They require significant amount of treatment, assistance, support, and care. Okay. Here is another mythology that is extremely common, that drug use leads to drug dependence. Again, it sounds logical because everybody who developed dependence, at some point they started using, experimenting, and abusing drugs. The question is whether everybody who is using drugs will develop dependence. If you look at the science, actually the science is very clear. Most people, most teenagers who start using drugs do not continue. Most teenagers, even teenagers who experimented with significant amounts of serious drugs for a relatively long time, most of them will not continue. Most of them will stop. Some, actually the minority, will develop problems and probably will develop dependence. And if you look at the numbers, if you look at the science is actually very clear. For different substances, for different classes of drugs, there is a difficult likelihood for teenagers who started with these drugs, experimenting with these drugs, to continue and develop potentially problems. And these are the numbers. As you can see, most of the teenagers, most of people who use drugs will never develop dependence. So drug abuse does not necessarily lead to dependence, and in most cases it does not. Here is another very common mythology. I've heard it many, many times in many countries in the world. And here what it sounds like. The patient has to hit the bottom, the patient has to be ready for treatment, and the patient has to wait until the difficulties will be so unbearable, then we can do something meaningful for this patient. Well, here's what we know from science. The earlier we involve our clients in any kind of meaningful treatment relationship, the more chances we will give the client to succeed and achieve long-lasting remission. What do we have in practice? Well, in practice, in most treatment programs, we have very long waiting lists, and the patients have to wait weeks, sometimes months, to be admitted to start treatment. Here is another very common belief: how long the treatment should last. Many people believe that the treatment process should be as short as possible to avoid life disruptions and avoid institutionalization of our patients. But the big question is, what is the effective minimum duration of treatment? What we know from science is the longer we keep the client in a treatment environment, in any kind of treatment milieu, the better chances we have with the client, the better chances we give the client to succeed. And for some reasons that I'm not sure if I know, the studies around about the duration of treatment, the effective length of treatment, the studies are very consistent, surprisingly consistent. That the minimum duration of a treatment episode is 90 days. In other words, people who have been treated for less than 90 days, regardless of the treatment model, actually the outcomes are pretty much the same like in never treated population. What is the magic of this 90 days number? I don't know. But most of the studies, outcome evaluation studies, show that treatment that lasts longer than 90 days, 90 plus days, this is the minimum dose of treatment that from this point further the outcomes are getting better and better and better. Does it mean endless treatment? Not necessarily. Treatment is a continuum of different activities, and we'll talk about it. But it means 90 days means the presence of a patient in a constant interaction with the therapeutic treatment providers in a therapeutic environment. So 90 days appears to be the minimum effective dose of treatment, length of treatment. What do we have in real practice? In most cases, treatment programs are 30 days or less. And the continuation right after these 30 days, in best cases, the only thing that follows is 12-step model, Alcoholic Anonymous or Narcotic Anonymous type of interventions. In most cases, nothing. Here's another very interesting belief. In many places in the world, in many countries, the biggest attention, the policymakers and the health providers, the biggest attention is paid to building detoxification programs. And now the new detoxification programs open one after another in country after country. And it seems like there is a common belief that detoxification is an effective treatment intervention. It's an effective treatment model. Let's take a look, what do we know from research? The research, actually all over the world, the studies show that detoxification alone, as a standalone intervention, if nothing follows, is not effective. People relapse, not even days after detox, sometimes, in most cases, even hours after detox. The only reason for detoxification programs to exist, and they're needed, detoxification is a very important step, typically the first step at the beginning of the therapeutic intervention, and detoxification has its goals. And primarily, the two primary goals of any detox program is, first, the patient is physically stable and the patient is alive. And secondly, detoxification time gives us a unique opportunity to start working on the patient's motivation to continue a longer-term, lifelong treatment process. Even though we know from science that detoxification alone, if nothing follows, detoxification alone is not a very effective approach, in real practice we have a huge number of treatment interventions with the only option for the patient is detoxification. And also, I'm sure you have heard about advertised programs for 5 to 24 hours cure for opioid detox as a way of making money. It happens in many countries in the world. So you see there's another discrepancy between what we know from reliable, good quality research and what we have in practice. Here's another very interesting and very common belief. The patient must be ready for treatment, and if the patient is not motivated for treatment, there is nothing we can do. It does sound logical. It does sound logical if the patient doesn't want treatment. At first look, what can you do? Well, again, let's take a look at the science. And this science actually gives us significant insight, suggesting that even in people who are not very motivated for treatment, there are still options. There is still something we can do. Let me give you a couple of examples. First, working with patients' motivation is actually one of the key and most important clinical skills in people who provide services. In other words, the patient's motivation is our problem, it's not the patient's problem. And also we know from science that the earlier we involve the client in a therapeutic process, the better chances the client gets to succeed and to achieve sustainable, long-lasting remission. Well, a couple of examples about illustrating what can be done with people who don't seem to be very motivated for treatment. This is one of the largest studies from the University of Denver on 4,000 IV opioid users who came to therapeutic programs with the request for HIV test. None of them asked for drug treatment. The only reason for them to come to the treatment program was they wanted the HIV test. From the medical ethics standpoint, we cannot deny people what they want, and this is a very legitimate question. They wanted HIV test, that's okay. So these 4,000 people have been randomly assigned to two groups. The controls, they got exactly what they wanted. They wanted the HIV test, they got the HIV test. The second half, the experimental group, they got the HIV test, but in addition to that, they had a chance to spend some time, relatively short time, with well-trained counselors trained in motivational enhancement therapy, in motivational interviewing and motivational counseling. So in addition to what they wanted, what does it mean, HIV test? We have to show up in a place, sit in a waiting room, spend some time there. Well, during that time, 10, 15 minutes in the waiting room, these patients had the opportunity to interact with people who have been very well trained in motivational enhancement. Remember, none of these clients, none of these patients wanted drug treatment. Here's what happened. Here's what we know happened 6 months later. These are the patients who got exactly what they wanted, the HIV test. 6 months later, more than half of them are still injecting, very few of them are abstinent, and a significant number, almost 25% of these people got arrested 6 months later. And here's what happened with the patients who received HIV test plus motivational enhancement. Do you see the difference? Remember, these are people who did not want any drug treatment. Here's another example. This is an excellent study from the Johns Hopkins University about pregnant women. All of them were cocaine-dependent, stimulant-dependent women who came to the hospital. They did not ask for drug treatment. They were pregnant and they asked for prenatal care, a very natural, normal, and quite understandable request. Using the same logic, they've been randomly assigned to two groups. They all got prenatal care. You cannot leave a woman who is pregnant without prenatal care. They all got prenatal care, but a half of them, randomly assigned, a half of them, in addition to prenatal care, they got the opportunity to interact with well-trained people in motivational counseling and motivational interviewing. Look at the differences. This is the percentage of women who have been tested positive for stimulants at the day of childbirth. 63% of controls, women who got prenatal care only, were tested positive, versus 37% of women who got the prenatal care plus motivational enhancement. Look at the weight and gestational age of the babies. A significant difference here. Look how many days moms with the baby stayed in the intensive care unit, and look at how much money did it cost. So did you notice that, do you remember that none of these women asked drug treatment? The only thing they came and they requested was prenatal care. So apparently, even people who appear not to be very motivated for treatment with some clinical skills in motivational enhancement and motivational counseling, there are still many things we can do, and people do get better, even people who do not appear to be very motivated. Let's move on. The issue of punishment and coercion. This is a very common belief system and very common mythology, particularly in people working in conjunction or within criminal justice environments. So punishment, pressure, coercion, compulsory treatment, and criminal sanctions are needed to force people into recovery. Well, let's be honest here. There is no single study suggesting that people can achieve sustainable recovery as a result of punishment or threat of punishment or coercion. Actually, there are many studies that indicate that a large number of patients, if they are subjected to pressure, coercion, and punishment, particularly young patients, they actually get worse. The percentage of relapses goes up. Look at this meta-analytical review. The meta-analysis of 67 very large randomized studies. They clearly suggest that if we utilize pressure, coercion, and punishment, actually the number of relapses goes up. If we offer people meaningful therapeutic intervention, actually they're getting better. So from the science we know that coercion, compulsory treatment, putting pressure on people, forcing people into recovery, it's not just ineffective. We are making people worse, which creates an ethical dilemma for us. It's not just not getting the outcome you want. We are making some people worse. And in fact, what do we have in our practice? The compulsory treatment programs are not uncommon in many countries in the world, and there are still some debates, should we continue forcing people into recovery or we should do something different. let me reiterate it once again. The science about the role of coercion and pressure and punishment is very, very clear. This is not the approach to force people, to help people to achieve sustainable recovery. Okay. Well, this is another very important and very common mythology. The treatment of substance use disorders is not as effective as treatment of other conditions. So there's kind of very, very common pessimism and pessimistic attitude about the outcomes of treatment of drug use disorders. Let's think about it. I would like to make a comparison between drug dependence and three conditions, comparable conditions from the general medicine. Let's call them so-called good conditions, because drug dependence is a bad disease. But there are some so-called good diseases like diabetes, hypertension, asthma, and these are very common conditions in the physical general medicine. Why they're comparable? Well, first, there is no doubt all these conditions are diseases. They're all chronic conditions. They're influenced by genetic, metabolic, and behavioral factors. We don't have cure for diabetes. We don't have cure for most of the forms of hypertension, but there are very effective treatment interventions for patients with diabetes and patients with high blood pressure, with hypertension. Let's take a look at what are the factors. What are the typical behaviors of patients with hypertension? How many of the patients with high blood pressure do exactly what the doctor told them to do? Actually, less than 60%. How many patients with hypertension maintain their diet and maintain their exercise and control their body weight? Less than 30%. Actually, most patients with hypertension do not do what the doctors told them to do. If you look at the data, how many of these patients need another treatment within 12 months period, you will see that more than half of these patients actually relapse in 12 months, and they need another treatment intervention. Let's see if the numbers are any different in patients with diabetes. How many of the diabetic patients do exactly what the doctor told them? Actually, very few. More than a half of patients with diabetes do not take their medication the way the doctor prescribed. Less than 30% of diabetes patients control their body weight, exercise, and keep on the diet. How many of them require additional treatment or new treatment within 12 months period? Approximately a half. Pretty much the same numbers for people with asthma. Let me repeat again, I'm comparing drug use, drug dependence with some other chronic relapsing condition in the physical medicine. And as you can see, the predictive factors for relapse in chronic physical conditions like diabetes and hypertension are lack of adherence to medication, to behavioral changes. In other words, people don't do what they've been told. People don't like doing what they've been told by their doctors. And most patients, particularly the patients with diabetes or high blood pressure, the so-called good diseases, most patients do not follow exactly what the doctor told them, for sure not at the beginning. So the lack of adherence is the most common reason for these patients to relapse and be in need of additional treatment. Another very important factor is low socioeconomic status. People with low socioeconomic status, they tend to do worse. They tend to need another treatment very quickly. People who do not have family support, substantial family support, people with diabetes or hypertension, they do poorly. And patients with additional psychiatric or psychological comorbidity, they tend to do not very well. And I'm talking about patients with chronic conditions from the physical medicine. If we forget for a second about general medicine and go back to our drug abuse treatment, you will see that the factors, relapse factors, are pretty much the same. People don't do what exactly they've been told. There is no support. This psychological and psychiatric comorbidity plays a major role as a relapse factor in our patients. And the factors are pretty much the same. So the question is, what we learn from chronic care, most patients with chronic illnesses do not respond well, for sure do not respond well to the first treatment episode. And this is why it's so important to retain them in treatment. We also learn from the addiction medicine that we can improve symptoms we cannot improve symptoms without behavioral change, and a simple counseling can actually help people with physical condition, with diabetes or hypertension, to get better. So then the question becomes, since these conditions, the relapse rates are pretty much the same, the relapses and recidivism, the relapse rates in diabetes patients and hypertension patients, and in patients with drug dependencies, since the number are very similar or almost identical. So the question still is why addiction treatment seems to be so ineffective. Well, one of the reasons why is because we evaluate addiction treatment in the wrong way. We provide treatment to patients with drug dependencies only when they are in really bad shape. Right here, when the symptoms are very acute, they're acutely using, they're losing their job, they're getting sick, they're in physical withdrawal, and all sorts of physical problems happen. As soon as they get better, we stop treatment. The treatment doesn't happen, and then when the treatment usually reoccurs, when they're in bad shape again. Can you imagine a physician treating a patient with hypertension as soon as we found that this is the medication that works? This is what the patient is doing, and now the blood pressure is under control. Can you imagine physicians to stop treatment? It will never happen. It doesn't make any sense. But this is exactly what happens in treatment of patients with drug use disorders. We, instead of continuous, ongoing, continuum of different treatment interventions, we actually utilize the acute treatment philosophy versus philosophy of treatment for chronic relapsing conditions. Here's what happens when we evaluate treatment of hypertension. You have a patient here with very high blood pressure. The patient came to you, you are a good physician, you are a good doctor, you know how to treat hypertension, and at the beginning of treatment, relatively quickly, most likely the blood pressure will go down and will be under control. But we know that hypertension is a chronic and relapsing condition. Even though the patient now is fine, as a treating physician, I really must be ready that at some point we will have some difficulties and I will need to increase the treatment and to do treatment again, okay? So nobody says the treatment of hypertension is ineffective. Actually, it's very effective while the patient is in treatment. If we utilize the same model and apply it to drug use disorders, the patient came here in a very bad shape. We provided this patient with meaningful treatment, and now the patient is doing well. But we know that drug dependence is a chronic and relapsing condition. The chances are that this patient will need another treatment. But nobody pays attention that during treatment, while the patient was in treatment, the patient was doing fine. Everybody says, well, he was using before, he is using after, your treatment doesn't work. You see, there is a paradoxical logical error when we apply the same philosophical evaluation model to treatment of chronic and relapsing condition in general medicine and to the treatment of patients with drug use disorders. This is the attitudinal problem in us. It's not a problem of the patient. Another very important argument, a very old argument, which treatment model is better in patients with substance use disorders? And I've heard it so many times, the argument, well, this treatment model X is better than treatment model Y. Actually, this argument doesn't make any sense because our patients are different, their needs are different, the severity profiles are different, everything is different. The only thing they have in common is they use drugs. So the conversation or argument that treatment model X is better than treatment model Y, or it's worse than treatment model Y, doesn't make any sense. Patients respond different to different treatment interventions. So the treatment intervention must be adequate to the assessed patient's needs. In order for us to make any determination, we need to utilize science. We certainly at the beginning of the 21st century, we are now 2014, we don't know everything, but the science made remarkable progress in the last 20-25 years. The neurogenetic science, the molecular science, the treatment outcome science. There's so many scientific, almost breakthrough scientific findings that we cannot afford to provide people with services based on ideology, belief system, or just because I think so. The science provides us with a huge amount of knowledge. So patients that we are working with, patients with drug use disorders, they deserve nothing less than patients with other chronic conditions in physical general medicine, like patients with diabetes, cancers, hypertension. They deserve the same quality of professional help, professional assistance, based on science, not on beliefs or ideologies. In order for us to do that, we need to have some level of curiosity, some level of understanding of the science, and the ability to understand science, to read science, and appreciate that science really helps us in building meaningful and effective treatment interventions for our patients. And the reason for this presentation was to increase our sensitivity that actually the science does help, and we cannot afford not to use science in our profession. Thank you.